Today we spoke with Ann Kearney, the director at the Wellness Center for Health and Counseling. She spoke a lot about the different types of mental illnesses that there are, not only on a national level, but also on a local level here at Moyne College. Here is our exclusive interview with Ann Kearney. So our first question is probably the most basic, and that is, do you feel that there is a stereotype surrounding the shooters of mass murders or just shootings in general?
Yeah, I think that the stereotype, I think there is. It's probably a young male that has mental illness.
And why do you think that these stereotypes exist? Do you think it's because of the recent shootings that have happened, and that's what people are perceiving from the media?
Well, I think the ones that have been in the media have been, young white men, although Cho was Asian. But yeah, I think, and probably the general public wouldn't say mental illness, they'd just say they're crazy.
Do you think that because people are misinterpreting the different facts of mental illness, that they are in essence sort of triggering the shootings done by these people who suffer from these illnesses?
Yeah, I think there's a lot that's probably misunderstood about mental illness in general. And, when people make terms like that in general, I think it's hurtful to those people who are really struggling with mental illness. And and I think it kind of simplifies something that's probably pretty complex, in terms of how this comes to be. But, I think it just probably, like most prejudice and stereotypes, comes from lack of understanding and, really deeper knowledge of really what's behind all that.
Do you feel as if the media almost maybe unintentionally interprets mental illness in a false light?
Yeah. But I think our human mind wants to come up with, sort of cause and effect and easy answers. And I think people jump to conclusions, kind of connect dots, but there's a lot more in between, that's not understood.
Well, I've noticed in the past couple shootings in recent years that mental illness always seems to come up when talking about the shooter. Do you feel like there's a common mental illness or two that seems to be among these shooters?
From the ones that I'm aware of, it seems like, I think schizophrenia, I guess I could put them in, there's a few probably diagnoses: schizophrenia, manic depression, because oftentimes there's a psychotic feature to even manic depression or even major depression, when there's psychosis involved. And I know a few of them, obsessive compulsive, disorders where there's really huge obsessions and delusions and, again, sort of loss of contact with reality. I think those would be the main ones.
Now, could you just explain to us what exactly manic depression is?
Yeah, well, the manic depression is the bipolar phenomena where there's a cycling of moods, a rapid cycling sometimes, and but the depressive part of both of those could look similar, and both of them can, when it's really, really deep, move into a psychotic, aspect to it. So, but yeah, with the manic, you tend to see, or the bipolar, kind of more that really agitated, very, and again, sometimes with obsessions, where there has to be rituals and a lot of, where you see collection of whatever types of guns and weapons, or, just different obsessions, I think, that sometimes are part of that.
So where do these mental illnesses come from? Is it genetic? Is it something that just happens to you? Like where does it all derive from?
I think it definitely doesn't just start or come on all of a sudden. What we do know is that actually the age of onset for a lot of mental illness is college age, young adulthood. between the age of 18 and 25 is the onset for a lot of the more serious mental illness. So even with that said, though, there's a lot of indicators often in earlier in childhood, middle school, and even in grammar school. So when there is, which I think for most of the serious mental illness, there's a genetic component or a predisposition. And then, of course, there's probably the environmental influence as well. And we do know that a lot of people that commit violent acts have history themselves of being victimized. And, you hear the stories of the bullying, and then the bullied becomes the bullier. And, if there's not intervention or treatment early on, there's this phenomena that can happen, not always, but where the victim identifies with the aggressor, and wants to have the power and the control and all of that. But certainly you can't say cause and effect, and we would never say everybody that's bullied is going to become a murderer or something like that. But we do tend to see a history of, challenges early on with a lot of these people. So, yeah, I think it's kind of the classic nature-nurture, it's probably the perfect storm or imperfect storm of genetics and predisposition, environmental influences over the course of their life, and then probably just a lack of really good treatment or inconsistent treatment, because we do know a lot of these can be remedied or at least contained at a better level when there's good treatment, good psychotherapy and medication.
What can we say to victims of mental illnesses who feel completely alone? Maybe it's for financial reasons, they can't afford to go and get help. Maybe it's for supporting reasons, they don't have anyone there to support them through this difficult time. I mean, what can we say to these victims of mental illnesses? What can we do to help them?
Yeah, that's the tough one, and that's probably why I'm a little bit of I am a supporter of, more universal health care, and that we have to provide access to care for everybody, no matter what, and that financial ability to pay or access to insurance should not be a barrier to receiving treatment. And I think we have evidence of that both from the physical health side, but also mental health, that if we don't intervene at the right time and early enough, then, these things become bigger and more ingrained and deeper and more problematic. So, and even with schizophrenia, there's lots of research that says if we can intervene early with medication with schizophrenia, the earlier the better the outcome. But if it goes untreated for long periods of time, the positive outcomes are less good. So, yeah, what can we do? I guess it's pay attention to politics and, who we're electing and what policies and, how our government is advocating for health care for everyone. And that could be both in our community, at our community levels also. I think there are some free clinics, but, they can only provide so much care. And there's just horrible waiting lists, and, there's a lot of problems with. Some people would even go to say that we don't have a mental health system, because a system means it's interrelated and coherent and continuous, and our system is pretty broken. There's not a lot of continuity. Yeah, what else could we do? I guess, the other sort of natural systems early on, when you think about church communities, neighborhood communities, just those social supports. So, I don't know, just probably lots of case scenarios, but say there's a neglectful parent. Maybe it's a mother that's a drug addict and the father's in prison, and maybe there's aunts and uncles and other people, because we know resiliency research does say if they have one person at least that's really digging in with somebody and providing continuity and love and support. And not that that's going to prevent mass shootings, but I think really the social network and the fabric is so important to, I think, both identify but then support recovery and, making sure people get the right treatment.
So now to bring this national issue more local, what seems to be the most common mental illness or mental illnesses here at Le Moyne College that you see?
Let's see, every year our numbers, we average about 300 to 350 students every year that we see, for counseling. So that's about 10% of the population. And we don't have to diagnose, meaning like the DSM-5, like the medical, clinical, because we don't bill insurance. So, but we definitely do sort of informally diagnose. And the number one diagnosis the last 2 years has been anxiety and, stress. Students call it stress, but it's anxiety and stress. And then the second one is depression. And then the third, what students identify is relationship problems. And that's not technically a mental illness or diagnosis, but, that's the stressor that they're coming in with: boyfriend, girlfriend, family, roommate, stuff like that. So anxiety, depression, relationships. And then really there's the fourth category would be a combination like bipolar, obsessive compulsive, and sort of the other, and we are seeing more students on the spectrum, the autism spectrum, and Asperger's in particular. But every year there's generally 1 or 2 or 3 onset of schizophrenia, which, like I said, during those years. And that's really difficult because students can go through all the way through their high school and, be, quote, normal, but, have relationships and be productive. And then sometime during the college years start having, and that's your classic kind of hearing voices and seeing things and just sort of losing touch. But we're really lucky in this environment that we can spot it early and get intervention early. And many of those students succeed. They continue and you wouldn't even know it, really.
Have there been any cases here on campus that have cause for some serious concern?
We are probably our biggest responsibility that we feel like we carry is making sure that students are safe themselves and that the campus is safe. So on all of our intake forms, we ask about suicidal ideation, we call it, but thoughts about suicide. And we ask everybody too, have you ever thought of hurting anybody else? And because there are times, especially with depression, not so much anxiety, but where it's like, what's the point? And oftentimes people with really deep depression feel very disconnected and isolated. And and there are students who have presented with like paranoid delusional system, like they think people are out to get them, and that's when it really is bordering on like a thought disorder, more of a psychotic episode, and where we're like, wow, they think people are going to be showing their picture all over campus. And so, yeah, there are definitely some students that we've worried about, that we're like, wow, are they, and the suicidal ones, honestly, are, I don't want to say easier, but we're more familiar with that because that's part of mental health treatment, all along. So, and we have students who go to the hospital, because they can't keep themselves safe, who make attempts, stuff like that. But the homicidal, the danger to others is definitely way more complicated. And so what we do is we will do the preliminary assessment where we will say, wow, this needs a higher level of assessment, and we do have experts in our community in Syracuse who are forensic psychiatrists, and Dr. James Knoll is really, if you look him up, we're really lucky to have him in Syracuse because he's known nationally for these kinds of assessments, forensic assessments. And like he was involved with Newton, the tragedy, down in Newton, and he went there afterwards. And what do they call it? They do like an autopsy, so to speak, of what happened and the person, and kind of looking back at the profile and what happened and how did it come to that point. But all of my staff and myself have been involved in multiple trainings on threat assessment. This is what we call it. And so we have a pretty good grounding in how to determine that. But it does not come up that often. I can say that. That's pretty rare.
Well, thank you so much, Ann Kearney, for doing this exclusive interview with us on gun violence, not only on the national level, but also the local as well. We really appreciate you talking to us today.